Welcome, everybody, to this year's quarterly webinar series. And this time, instead of our usual agenda, we are going to be talking about blowing up the value equation, rethinking value in healthcare, and how we can get there all together. So everybody who's joined us today is on mute and will be throughout our hour. Please write any content questions in our Q&A box and any technical issues in the chat box. We will be monitoring both throughout the webinar. Additionally, we are recording this. You might have heard that little announcement earlier, and this recording will be posted on our YouTube channel and sent out to everybody as a link after. On behalf of the BRE Collaborative at the Foundation for Healthcare Quality and the Washington Health Alliance, I am very grateful for your intention, really, to improve healthcare quality by joining us today. I am Ginny Weir, CEO of the Foundation for Healthcare Quality, and a huge thank you to Nick Locke, Emily Robson, and Carrie Nicholas at the Foundation for Healthcare Quality, and our fabulous partner at the Washington Health Alliance, Dr. Sharon Eloranta and Denise Giambalvo, in partnering with us to help plan this session. So our state defines value-based care really in alignment with those by CMS. So 4 categories that most of you are probably quite familiar with. We've used them throughout this webinar series as we move from fee-for-service with no link to quality or value to population-based payment. And our team at the Foundation and the Alliance really wanted to know why this wasn't happening already. And so we borrowed from our state's healthcare authority. They've conducted surveys of payers and providers over multiple years to help find the top enablers and barriers for both groups. So 4 of these barriers and enablers, social determinants of health, interoperability, aligned quality measurement, and multi-payer strategies, became our accelerators for change in 2021. And we challenged our community to take a meaningful step in 21 and offer the same challenge in 22. It's now my pleasure to introduce my colleague, Dr. Drew Olivera, newly Executive Director of the Washington Health Alliance. I've had the pleasure of working alongside him at the BRE Collaborative when he was with Regence, and I'm really glad to continue this transformative work with him in his new role. How has your first month been, Drew?
It's been really enlightening in a couple of ways. One, just sort of sitting in this seat and being able to think more broadly about how do we implement change? How do we really make a difference and drive that change in the market? How do we create value? And we're talking about value today. And as you know, we've been involved in a number of different initiatives that develop guidelines, develop processes, et cetera, over the time. But it's how do you get that implemented, and how do you get it implemented in a way that actually works? And that's sort of what started to keep me up at night.
Yes, I'm with you there. That implementation question is sort of a perennial issue for us as well. How are you actually changing the way a person experiences healthcare, experiences care? So let's talk a little bit about value. One of our big things, of course, is looking at the literature, looking at the evidence, and a recent Harvard Business Review article really asks or says, it turns out one reason there's been little progress in creating a value-based system is that all of these stakeholders, patients, providers, hospitals, insurers, policymakers, don't really have a common definition of value and don't really agree on the mix of elements that make it up. Is it quality? Is it service, cost, outcomes, access? So how do you define value, Drew?
Well, if you asked me 25 years ago, I would have been pretty simplistic, right? I would have said, hey, it's quality over cost, right? Everyone knows what quality is. Well, maybe we don't, but we think we do. And then it's over cost. And then maybe if you asked me a few years later, I might have said, well, it's also appropriateness times quality over cost. That would get us there. The reality is it's way more nuanced than that. And we make a lot of assumptions, right? And those assumptions have to be seen in context. So one assumption is if we do an intervention, it's always going to have the same effect. And that's clearly not going to be true. There may be an evidence-based intervention that's out there, but it has to be the appropriate one, right? We know misdiagnosis can happen, 25, 30% of the time. it has to be really clear what intervention is being delivered. You're trying to get unwarranted variation. So we see that a lot, for instance, in cancer care treatment. We've got great guidelines by NCCN, but 30% of the time they're not being used, or actually maybe a little bit more. And then you have to think about things in the context, right? So the context varies on who you're thinking about. Is it the system, the health system in general? Is it an organization within that? Is it a provider? Is it a patient? Because they all will have their own context. You know, they may have different abilities to do things, and how they therefore implement that strategy really depends on how well they can optimize their context or their system to be able to work. And so that's going to really sort of change how we think about value in a way that sort of gets you to all the things you mentioned before. Is it a population health question, right? That might be from a system standpoint. Is it optimizing how you deliver service? That might be your, you know, your organization, your hospital system, et cetera. Is it the purchaser view, which is, you know, maybe I just want to lower costs. Maybe that's a health plan view as well. The patient may also have a different definition of what value is for them. So they probably won't say, you know, value is having, you know, no complications from my knee replacement. Value is, yeah, I'm able to walk with my grandkids, right? So value, we have to think about it in multiple different ways, because if we can do that, then I think we can deliver success depending on where that context occurs. A rural setting, an urban setting may look very different when you think about what value looks like from an evidence-based intervention.
Yeah. Agree with all of that, especially the way that it's sort of changed over time, I think, for all of us, and would add a little bit maybe the community health aspect too, right? We've all, you know, become epidemiologists in the last 2.5 years as we've dealt with this pandemic, and really can see the impact of the lack of access and vaccination on those in our community, and really what that, how that really impacts us and how we can go through our daily lives too.
Absolutely. I think, you know, I'm really excited to hear from our panelists, because, you know, they're going to be able to bring in a variety of different insights by just talking about, you know, sort of where people live, what's the impact of community. All those things are really interesting. And I'm really looking forward to seeing our data in Q1 at our community checkup, because we'll be putting that into context a little bit. You know, what happens if you're in a more privileged area versus a less privileged one? How does that impact your clinical care? How does it impact it based on whether you have commercial insurance versus Medicaid? Because what we're seeing is sometimes it's not what you think, that Medicaid may look much better in certain areas and commercial a lot worse, and vice versa. So I'm really excited to hear what our panelists have to say, and especially related to, you know, some of those contexts as well.
I agree. I'm excited for that community checkup report and how the social determinants of health are showing up. I think that's a pretty exciting place in a way that the alliances work and help speak to value. And at the foundation, I think we've done some really exciting things around SDOH too, adding information at the start of this year in our obstetrics care outcomes assessment program on housing and food insecurity and transportation, working to find patterns within these demographic factors and matching those, finding associations with obstetric care processes, maternal health and newborn health outcomes. We've gotten some local and national attention, so it'll be exciting, I think, to really build on that. And I think good things lie ahead for obstetric care in Washington State. And of course, implementation of our BRIE guidelines, very tied to this accountable payment model space, this value-based payment space. Really making the right thing the easy thing is one of our goals, and look forward to how this webinar can really help that happen.
Morning to discuss your experience, your national perspectives on value-based payments. I mean, value-based payment really is the trillion-dollar question in our country. We spend over $4 trillion on healthcare but we've all seen how, despite spending this much, we've seen poor outcomes and disparities. As Dr. Olivera alluded to, the traditional value equation, value equals quality over cost, may be insufficient when we're thinking about the complexities of how we pay for care and what type of quality we're seeing from our care. But before we jump into our conversation on that very complicated topic, I'd love to give all of our panelists some time to introduce themselves and describe some of their current work on value-based payment. Dr. Wolfe, would you like to go first?
Sure, thanks so much, Nick. And it's a pleasure to be here with my expert colleagues on this panel. I'm a family physician. I've been in practice for 11 years, and I also have served as the Regional Chief Medical Officer for our CMS offices in the West since 2015. So my background really is not only in whole person care, but also from the public health and public policy side of things, looking at our communities from a population health perspective. And that's been a really exciting thing to incorporate into my work at the Centers for Medicare and Medicaid Services. As you all know, there's been a lot of activity in the value space from not only the Centers for Medicare and Medicaid Innovation, or the Innovation Center as we call it, but also in a variety of other ways through our regulations, our payment regulations, and simply in our requests to engage with our stakeholders around now current issues of health equity and opportunities to not only lay further foundations of quality across all CMS programs, but also looking specifically at a cohesive value-based strategy for CMS. And some of you may have seen in a relatively recent Health Affairs article, our administrator, Chiquita Brooks-LaSure, as well as some of our other senior leadership, tried to outline pretty ambitious goals for CMS in terms of having all those with traditional Medicare in what we've called an accountable care relationship with a healthcare provider by 2030. And the details of sort of what does that mean, how are we going to affect that change, are some of the things I'm going to get into as we talk today. But really, our leadership has outlined our value-based strategy around three things: alignment, growth, and equity. And in various ways in my position, I have a chance to understand from our clinicians practicing in the field their perspective of where are the most important pieces of that strategy and how can CMS move forward. So again, just thank you for having me today, and I'm really looking forward to our conversation.
Thank you so much for joining us, and I'm sure we'll dig deeper into some of those pieces about equity and measuring quality as we move along the conversation. Dr. St. Clair, would you like to go next?
Yes, thank you so much for having me. It's a pleasure to join you today. As mentioned, I am an OBGYN anchored here in Washington State. I have been, and I'm very, passionate about health of our state and health outcomes. Now that I've newly joined Regence, it's been wonderful. And we've done a lot of work looking at what are the best ways for us to be approaching our value-based relationships. What are the best ways to define value? What are the best metrics that not only maybe resonate from a classic health plan perspective, but as Drew mentioned earlier, really thinking about all of the stakeholders and what are the ways that we can make sure that the work that we're doing in our plans is driving value for the organization, for the providers, for the community, and the patients. And, each of us are the people receiving the care. One of the things that I'm excited to talk about as we kind of get more into this is how we define value, and really just kind of identifying that it's pretty subjective. If you look at the definition of value, it's really the worth of what you're getting, which is something that's intrinsically subjective. So I think really kind of diving into just how we think about value as we're structuring our arrangements has just continued to be the focus.
Yeah, thank you so much. I appreciate the highlighting how these really require partnerships across both public and private partners. And so thinking about how we can create those partnerships and make sure that they're sustainable is really important. And last, but certainly not least, Matt.
Yeah, thanks. And I'll start with a disclaimer about my current status is that I'm recently retired from KP. So my comments today are my own, although I think entirely consistent with KP's perspective. And my perspective on value, I think, derives in large part from a 40-year career in Kaiser Permanente that doesn't stem from a history of payment for volume, but from within a system of prepaid capitation where payment for volume is rather foreign to my thinking. And also from my time at IHI, where I was there during the early days of the triple aim, really sort of colored my thinking about value. Since my work at KP and during the time I was there, a lot of my
so I think we can go ahead and restart our panel to make sure we can get through our pre-prepared questions and then have some time for audience questions at the end. So Matt, please feel free to start over from the beginning. So my apologies for cutting you off.
Yeah, I'm just happy to know it wasn't just me. So just to move forward, I won't start from the beginning, but I would pick up where I left off, and that's that I was talking about what shaped my perspective on value, and a lot of my work during and since KP has been on measuring outcomes, and especially lately on the measurement of well-being. And related to Nicole's comment about what do we mean by value and value being personal, I do think it does ultimately have to do with what we care most about. And I might argue that what we care most about is our health and well-being, but more later during the discussion on that.
Well, thank you. Thanks for that perspective. I think sort of alluding at how we define value might change how we measure it, and therefore change how we're thinking about success of these models. I do have a few pre-prepared questions to introduce to all of you, and any of you can feel free to jump in as you see fit. And then if we have time near the end, we can move to audience questions. So also audience members, if you have questions at any point, please feel free to put them in the Q&A box. But first, for most of our history, we have paid for healthcare in ways that encourage more services, whether they improved health or not. The Center for Medicare and Medicaid Innovation began 10 years ago to test innovative payment and service delivery models to transform our healthcare system from one that pays for volume to one that pays for value. In a New England Journal of Medicine article, former Chief Brad Smith says that while some models have delivered some positive tangible results, including about 5 that showed financial savings and several others that demonstrated improved quality, the majority of these delivery system innovation pilots have produced neither. He did lay out the following lessons learned: allowing voluntary participation, issues with cost benchmarking, the inability to collect meaningful quality data from control groups, and difficulty and errors administrating a new financial arrangement. So to begin, I want to start by talking about this piece around voluntary participation, sort of touching on the stakeholder piece that Dr. St. Clair mentioned. Part of the problem with our current value-based payment models may be that they focus on driving change through public payers, when we'll need more than just public payers to engage in payment models to make change. So my question is, where have you seen success in public-private partnerships to collectively drive change?
I can start, since the Innovation Center was called out a little bit in that question, and then defer to my colleagues on the panel. But as many of you know, so it's been about 10 years that the Innovation Center has been in place and was really authorized to look at these issues of quality and cost explicitly, defining actually the success of some of our models as being able to raise quality and decrease cost in the ideal, that's the ideal scenario, in order for those model tests to actually be expanded. So there's an actuarial definition actually built into the authority for the Innovation Center that is, again, quite simplistic in its definition of value. But as many of you know, the Innovation Center has actually looked very carefully at lessons learned over the last 10 years, and relatively recently published a white paper early this year articulating new strategic objectives for the Innovation Center, and specifically recognizing that quality and cost, while critical, are not the only thing we should be talking about when it comes to value. And in the addressing the issue of participation, be it voluntary or mandatory, we've seen some interesting models from the Innovation Center and some interesting lessons learned that I will just briefly mention. I think many of us can recall the comprehensive joint replacement model as one that started off in a mandatory approach, requiring almost every hospital in 67 specific metropolitan statistical areas to participate in addressing quality of care and managing cost across the system. That began in 2016. And over time, challenges with the implementation of that mandatory approach to the model created some changes, whereby CMS then made the model less mandatory, reducing the number of hospitals who were required to participate. And then finally, as of October of 2021, there are only hospitals in 34, so about half of the locations previously required that are actually required to participate. And those hospitals have to have very specific designations, not being rural, not being a low volume location. So there's been some adjustments to this model where I think from the required participation from the clinician and provider side has influenced how this model has worked over time. And we've published a series of lessons learned from the comprehensive joint replacement model thus far. Again, this model being requiring participation on the clinician side, but being an exclusive model when it comes to who's paying for this care. It's not a multi-payer model. It's a Medicare specific model. And interestingly enough, we've seen improvements in spending from hospitals who were required to participate in the model in the first 4 years. Some improvement in post-acute care utilization, but limited impact on the quality of care and specifically on outcomes for those who had a joint replacement as a result of a hip fracture. So some of the key quality impacts that we were looking for in this model thus far have really not materialized, which is an interesting point to make when you think about requiring participation. It's not necessarily just the clinicians that need to be involved here. There may be some other areas of value where we need to look. And in the lessons learned paper that CMS and the Innovation Center published earlier this year, we specifically called that out, that some of our models historically have not been very well streamlined. They've been highly complex. They've been very difficult to scale. And the design of the models themselves may not consistently ensure clinician or payer participation. And the complexities there really do limit the ability of what we're able to evaluate as the model moves forward. So when it comes to participation, I think part of what we're really talking about is alignment and recognizing that there's hardly a clinician in the country that doesn't work with multiple payers. And so the Innovation Center has actually committed moving forward to really looking, not exclusively, but almost entirely at multi-payer opportunities. And one of those most recent examples is the voluntary enhancing oncology model, which was again announced earlier this year, which has specific goals looking at the oncology space, which Drew pointed out is an opportunity, an ongoing opportunity for identifying value. It's highly complex care. It can be incredibly expensive. And there have been some lessons learned from our previous oncology models where the idea of engaging patients and engaging payers, as well as the clinicians themselves, has proved fruitful in improving quality. So the goals of this new model are actually really designed to best test how we can place patients at the center of care while requiring participation from multiple payers in a given area where there are clinicians participating in the model. And overall, really looking to improve outcomes as well as addressing health equity. So each of these practices that may participate in the model are required to actually screen their patients for health-related social needs and analyze information about their patient population to identify where specific goals of care may need further focused discussion. And so I think this model is an interesting example that, quality and cost are still very important, but they're not the only ingredients in value. And there are other things that need to be considered when we're developing models and we're hoping to identify that secret sauce that allows for improved outcomes. So, thanks very much.
So I can add on, that was great. And I think you made some key points. And I love the work that you just described that's happening. I think, obviously the best is when participation is voluntary. I mean, I think that's an easy statement to make. And really, I think when goals are aligned, then everyone should want to participate. And when you take a step back and look at the goal of a value-based payment arrangement, really all stakeholders should be in alignment with where we're trying to go. But I think sometimes where the breakdown can be is coming back to how are we defining value? How are we, I think when there's something that's pretty obvious, where we can say, this is the care that everyone should receive, all parties are in alignment, then sometimes just figuring out how to practically implement that. But when you take a step back and think about why are we receiving resistance, I think we just have to kind of go back to being clear on, what the clear outcomes of the intervention are to be. And so, as you mentioned a little bit about kind of bringing in payers, I agree that, having multiple payers in a region is key. But again, it should be clear to all parties involved why it's in their own best interest to participate in these programs if we're really true towards our goal of sustainability, as you mentioned, patient-focused care, and really truly paying attention to the outcomes as the bottom line.
Let's just add one thought, sort of based on the premise of your question and my introduction, is that the premise is that we've lived in this system of payment for volume forever, and I haven't. In the prepaid capitation world, and I think one of the challenges of value-based payment is that it straps on a whole lot of incentives and measures and additions to an underlying system of payment that still at the core is based on payment for volume. And I think that illustrates a number of the challenges faced with value-based payment. The concern about prepaid capitation has always been it will create incentives in the opposite wrong direction of withholding care. And I think that was a lot of the HMO backlash of the 90s. All I can say is that hasn't really happened in Kaiser Permanente. And if you look at all of the quality measures and the Medicare 5-star measures and that sort of thing, it's hard to point to the effect of withholding care through capitation. So just want to make that point that strapping on incentives and lots of measures and regulation to the underlying system that was precipitated by payment for volume, I think is part of the problem that we're facing.
Yeah, thank you all. I think we've heard a lot of key points there about making sure that we're creating alignment across stakeholders and hearing about how alignment could be created by making sure we are all understanding the incentives, but we also don't want to misuse incentives or create incentives that are being misused in the system. And I think that sort of gets at a bit of our next question, which is that we know that the traditional definition of value has been value equals quality over cost, sometimes multiplied by appropriateness, but many critiques of value-based care urge consideration of whether we can actually accurately measure either cost or quality. Some critiques suggest that our current quality metrics are just white noise to providers, or that these metrics can be easily gamed or evaded. Do any of you have an example of a quality metric that you believe has driven improvement in clinical practice?
I just sort of back to the premise just for a second first about in one of the articles pointed to, well, we don't really know how to measure quality or cost, therefore it's problematic. Well, there's a bigger problem. If that's the case, we may as well just throw up our hands. It's kind of an Alice in Wonderland scenario where if you don't know where you're going, it doesn't matter what road you take. I think that's a bit of an extreme critique that we can't measure either quality or cost. I think there are lots of measures of both. Maybe that's part of the problem. but even back to this notion of the traditional definition of value being quality divided by cost, that's not really an operational definition. Quality, what's a unit of quality, and how do you trade off units of quality to come up with an equation like that? And we have lots of measures of quality, but no standard units. And besides, it may be sort of missing the mark. I think has already been alluded to, is quality the thing that we ultimately care about? Of course, quality is fundamentally important, but in a sense, quality is a means to an end. It's a means to an end of having outcomes, health outcomes that people care about. So I would sort of challenge the definition, and I can come back to that a little bit later in talking about the triple aim.
Yeah, I think you really, just to piggyback from what you said, it's really all about outcomes, right? I was taking a look at this survey, this provider survey from the Physicians Foundation. And one of the things that it highlighted was almost half of the providers had some element of their, reimbursement tied to a value program, but less than 20% of them actually felt that those programs were going to make a meaningful movement on outcomes. So, why is there that disconnect? And these are from the producers of the service, the providers, And so, I think that really says something there. And kind of calls out that maybe we're not putting the emphasis, or maybe we're not keeping the outcomes properly at the center of the quality discussion and metrics that we are generating. I think when you look at most value-based programs, a lot of them follow metrics that are excellent, that are evidence-based, metrics that are universally shared from CMS. We look at, things such as hemoglobin A1C. It's not debatable that having your diabetes under good control is going to lead to you having better outcomes in life, although the timeline can be fuzzy there. But yet we have these things that we all know to be true, but why is there such a disconnect from the providers of, I'm following these protocols, I'm checking these boxes, but I'm not sure these are really going to change my patient's outcomes. So how are we able to get to the patient something that they identify as valuable, that gives them an outcome that they feel was worth the cost that they perceived that they paid, whether that was in time, an investment in the treatment, in just the cost, the actual, dollar cost of care, all of that.
Absolutely. And to add on to that, I think it's 20 years on, it's sometimes easy to forget just how fundamentally earth-shaking the To Err is Human and the Crossing the Quality Chasm reports really were in the late 90s and early 2000s, and how it really called out a need for us to pay attention, even in the most basic level, of how we were clinically providing that care and where there were opportunities for improvement. And yes, CMS being one of the sort of nexus points for lots of quality measures with lots of quality improvement and reporting programs, we still continue to hear that stakeholders believe that measuring quality is an important part of what they're getting from their healthcare, and it's part of the value that they seek. But of course, we've heard the critique from on the patient and beneficiary side, as well as on the clinician and provider side, that there are so many measures, it's difficult to know what's important. And so it makes it difficult for clinicians to identify those opportunities for improvement. And it's difficult for patients to know and sort out what the quality factors are that make for a good healthcare experience. And so I think that's really part of CMS's challenge now. I think we could look to a number of programs. The Hospital Acquired Conditions Reduction Program is one, which has had a lot of critiques over time, but no one wants a central line acquired infection. And the CLABSI measures there have been tracked for a long, long time. And we've seen significant improvement from 2008, when we had about 40,000 central line associated blood-borne infections, to 2016, where that number was cut in half. So it also takes time to do this improvement, but I think it's reasonable to ask, if we weren't measuring CLABSI, would we have seen any improvements, or would we still be looking at 40,000 infections a year, which obviously creates significant morbidity and mortality in our acute inpatient population? And of course, it's not just measuring quality that's important. It's that we're identifying where the right quality measures make impact on outcomes. And it has to be relevant to the patient's goals of care, as my two panelists have also articulated. And so in some ways, that's what CMS is really looking at right now. And we've articulated a strategy through what we're calling Meaningful Measures 2.0, where we're really looking at high priority areas for improvement, with the goal of focusing on outcomes for patients and their families, as well as for those who are actually being measured, so the clinicians and the providers in the facilities. And so with this Meaningful Measures 2.0 initiative, we're actually updating and simplifying our measuring framework. It takes time, but our goal is really to have fewer priorities around the goals of care, and focus on measures that are really related to person-centered care, the outcomes of care for patients, and in particular, folding in issues of health equity in addition to affordability and managing safety, et cetera. So it's a really interesting opportunity and time. I think Don Berwick may have said it best when he said this is really the new era where we need to focus on the quality of our quality measures, as opposed to measuring for measurement's sake. And that's really something that CMS is moving forward with in our Meaningful Measures 2.0 initiative. So it'll be interesting to see how that conversation continues over time.
Thank you, everyone. I think I'm hearing that perhaps when we're looking at the broad value equation, it's more useful as a model, or to think about how we're paying for care. But when it comes to some granular services, there are some very useful quality metrics that we can be looking at, and we do need to be intentional with those individual quality metrics as we're moving forward and thinking about payment. There are two questions in the Q&A that are sort of related to this conversation, so I wanted to jump to those now. The first is from Suzanne Dade, which says that there was an article this morning about 2023 insurance premiums likely being raised 6 to 12% in the commercial sector. Without a similar or larger improvement in quality, this would lead to a significant decrease in value, according to that broad value equation. Are there any comments from our panelists potentially about how this will be addressed with consumers?
Well, I can, one thing that just jumps to mind from that question, I think, is it illustrates the flaw in the simplicity of the equation to just say, quality over cost. As costs change, you want to have that link to quality. But right now, as the equation is written, it clearly leaves out some factors that really are at play. I mean, it's an oversimplification, to just say that this is what it is, just quality over cost.
Thank you, Dr. St. Clair. Oh yeah, Matt.
Well, I would just add that 6 to 12%, that's, I agree with Nicole, that's the flaw in the value equation, is that you don't have some commensurate measure of quality that rolls up to be able to determine if the 6 to 12% is worth it. To determine if it's worth it, it has to be sort of an improvement in something that we as individuals and as a society care about. And again, I would come back to measures of population health. That's still challenging, obviously. We can, I mean, if time permitting, we can talk a little bit more about how we might measure improvements in health to compare against that investment. But without it, we're lost, and we don't know how much to invest. And just a brief comment about social determinants. And if we're thinking of the value equation being something about the health of a population, if that were the case, we probably wouldn't be investing so much in healthcare, and probably would take some of that money and reinvest it upstream, like many other countries in the world, because I think arguably a lot of the production of health comes upstream of healthcare.
Thank you. One other audience question that's sort of related to our current conversation. Given the multiple payer environment from the provider's perspective, the wide variety of innovation strategies arguably creates a substantial degree of administrative burden, thinking about some of the incentives that we were talking about, which includes operational costs incurred through participation in these strategies and measurement strategies. So this is a two-part question. One, do the benefits of participating in these strategies offset the provider's costs? And two, how might we do a better job in coordinating the many competing strategies for value-based payment in a competitive environment?
I think this is a really interesting question because it gets to the heart, in some ways, of CMS's current strategy to further drive value. And specifically, when it comes to looking at opportunities for alignment in the multiple payer environment, CMS is obviously a key player because so much of our, so many of the measures that we are using are also being used by other payers to assess quality. But depending on the payer, and CMS included in there, but not limited to, there are likely different ways that the same quality measure or the same operational structure is being used for different purposes with the same group of clinicians. And so in some ways, to answer question number one, the benefits of participating in some of these multi-payer strategies may be because there is a requirement of alignment across payers to use the quality measures for the same purposes, be that the same sort of performance-based incentives, be that the same data reports that are coming back to the clinicians to identify opportunities for improvement, et cetera. But of course, there has to be a compelling reason for those clinicians and those providers to change from the status quo. And that's the question CMS is getting most often right now, particularly with MIPS and the quality payment program, is I'm doing really well with this approach to that program. So why should I make a change towards an alternative payment model or a different strategy? So I think CMS has a lot of work to do to provide the answer to that question.
Thank you, Dr. Wolfe. I want to move us to probably one last question, as I see that we are nearing the end of our time. So we know that many of the financial incentives that are currently being used are too weak to drive change, or perhaps have too diffuse of measures for delivery sites to prioritize. We have seen a few successful models, two of which include bundled payment models and accountable care organizations, that could potentially be the foundation for future growth. However, when we're thinking about working with patients, assigning patients to a single provider, team, practice, medical group, or accountable care organization is sometimes seen negatively, as if it's taking away choice and perhaps reducing the value that they perceive. So I'm wondering, how should we be balancing patient preferences for choice with some of these value-based models that we know work?
Well, you know, I think that patients want to choose, but really what they want to do is have the ability to choose the best service. And I think in general, you know, patients also want to, they want to have the best outcome. And so I think part of it is just making sure that you're kind of clear in your foundational knowledge, that the rationale as to why you're aligning this patient. You know, you can tell them, this high performing, network, or this alignment, this organization that we're having you aligned to, the reason that this is beneficial to you is because you will receive the care that we know has been validated to be most likely to get you to the high quality outcome that you want, to live your healthy life, and at a reasonable cost, an efficient cost. I think I mentioned before, when you clearly illustrate how all of our goals are aligned, I think you'll get agreement. And I think that from patients, there's a simplicity of knowing that you're with a health team that you can trust, that are following best practices that perhaps you yourself aren't understanding. There's lots of research that's out there for patients, but it can be intimidating. And so often, I know I've been told, I actually want to go to a provider who I can establish a trust with. And when I want to, kind of go off on my own, I can, but otherwise I can just know that you are quarterbacking and handling my care in a quality and efficient way. And I think if we are really kind of clear in understanding that the purpose of that alignment is to get to that good quality outcome. And also, certainly it's, within your choice, where you kind of anchor yourself. I think that there would be less feelings of loss of choice and a better understanding that I'm receiving a valuable service here.
Yeah, and I agree with Nicole. I think to some degree, it's about how you define value and who is actually defining that value. And from patients, we at CMS, we have very specific ways of addressing and maintaining beneficiary choice, even in some of our innovation center models. And so what is of greatest value to our patients? Is it the perceived choice of provider, or is it having a stable relationship? Is it something else? Can that perspective be reconciled with the perspective of the clinician who would like a well-aligned system so that they only report on their quality measures once? And then how do we reconcile all of that with articulating the value of a non-event? In other words, the value of prevention. And I think in some ways, that is a piece of this discussion when it comes to helping the person understand where the value, quote unquote, is in the accountable care relationship or in the empanelment. But it has to be able to be demonstrated in a way that meets that patient's goals of care. And right now, I think that's the crux of the issue. There's so much research around the work that's being done that's incredible when it comes to looking back at where we've been 20 years ago and where we are now. But we really haven't done a good job of articulating on behalf of the person receiving the care where the value lies. And in particular, many of us know that creating that accountable care relationship, that care opportunities for care coordination, it makes a huge difference. The Medicare Shared Savings Program, ACO program, is a great example where clinicians in that program have higher quality ratings, better outcomes, and the program's saving the Medicare Trust Fund money. But that's a really challenging concept when it comes to saying, okay, so patient, this is why you should pick me as your clinician. So I think that conversation is a real big piece of where we go next when it comes to articulating the value behind some of our programs at CMS.
Thank you. And I know, Matt, you wanted to briefly sort of touch on, we've been talking a lot about how we define value and whose perspective are we using to define value. So I was wondering if you had a final comment there.
Yeah, and I see our time's short, so I'll be real brief, but I just wanted to comment, it's perhaps instructive to look back at the triple aim in thinking about what we mean by value in terms of care, cost, and health, and looking at the relationships among those. The relationship between care and cost may have something to do with efficiency, like how much care can we provide for a certain level of cost. But that's not really value because it doesn't take into account outcomes. The relationship between care and health may be defined as clinical effectiveness, which is how we evaluate drugs in this country, but it really doesn't take into account cost. So that's not really value too. But the relationship between health and cost may be a better frame for looking at value than relationship between quality and cost. And I think that that's the direction that we need to take it. Obviously not easy to come up with common metrics of health, but I think we have movement in that direction in terms of both self-reported health and functional status, both measured subjectively and objectively.
Well, thank you, Matt, and thank you to all of our panelists. I think we had a great conversation about where are the incentives, who's involved, and how we are defining both value and quality and cost. So lots to think about as we move on from today, but I'll turn it back over to Ginny as we start to close today's webinar.
Thanks, Nick, and thank you to everybody for being patient as we sort of worked through all these tech issues. I know that can be very frustrating, right? And kind of gives us all the opportunity to get to calm and practice our meditative breathing. So Drew, thank you for joining me again. And one of the things that really struck me, of course, is the opportunity that both pro organizations present to build trust between all these sectors, right? And to create these spaces where people can be vulnerable in this learning and public opportunity. What was your biggest takeaway from the webinar, aside from tech issues?
Well, I really like the broader definitions of what value is. But what we heard from, the panelists was alignment really matters, and value may be different depending on how you're looking at it. Moving things upstream makes a difference. But if we're going to get stakeholders to change, they need to receive some form of value satisfaction. And value satisfaction, in my mind, is, are they likely to receive that value? Is it attainable to them? Is it super hard? As what as many of those things are, or is it yeah, we could probably get that, and then what risks are associated with that? Do we have a high cost to be able to achieve that value? We may not want to do it as an organization, or is it a reasonable risk that I can get to it? So I think as we go forward, thinking through how we can best align all the different stakeholders, I think will be increasingly important given limited resources and staff and everything else that we know of.
Yeah, it's very true. We have some great resources in Washington State too, like the Performance Measures Coordinating Committee and other opportunities to really align specifically around measuring quality and trying to move our whole healthcare system there. And I know you and I are both involved with that. So stay tuned, and thank you to all our attendees, and many, many thanks to our 3 speakers and for rejoining twice as we got kicked off multiple times. So be well, and we will all see you soon and at other meetings, I'm sure. Bye now.